Fetal growth has been divided into 3 phases during the pregnancy. Initial phase of hyperplasia occur in the first 16 weeks of gestation and characterized by a rapid increase in the cell number. The second phase, which extended up to 32 weeks gestation and characterized by both cellular hyperplasia and hypertrophy. After 32, fetal growth is characterized by cellular hypertrophy, and during this phase, the most fetal fat and glycogen are accumulated. نجي على definitions. Fetuses with an estimated fetal weight less than or equal to the 10th percentile are classified as having fetal growth restriction, FGR. Those with a weight more than or equal to the 19th percentile are classified as large for gestational age, LGA. Both FGR and LGA fetuses have increased risk for perinatal mortality, morbidity and mortality. Determinants of fetal growth and birth weight are multifactorial, so there are many factors has a role in assessment of fetal growth, as fetal genome and epigenome, and also by intrauterine environment, which is influenced by maternal and placental factors. Birth weight, therefore, is a result of interaction between the fetus and maternal uterine environment. Definitions. Fetal growth restriction is used to describe a fetus that has not met its growth potential and defined as estimated fetal weight at or below the 10th percentile for gestational age. FGR indicates that there is a pathological process operate to restrict the growth rate of the fetus, while small for gestational age is term used to describe an infant that is less than 10th percentile at birth. And it's important to remember that most small for gestational age fetuses are constitutionally small and are not compromised. Pathophysiology of symmetrical versus asymmetrical growth restriction. Symmetric fetal growth restriction means that all organs of the infant are decreased proportionally. Also, symmetrical FGR infants are more likely to have an endogenous defect that results in impaired of early fetal cellular hyperplasia. Also, symmetric FGR have proportionally small brain, usually because of decrease in the number of the brain cell, and the cause is more often a genetic disorder, infection, or other problems. Symmetric FGR is referred to infant which organ are decreased disproportionately. هنا الabdominal circumference is affected to a greater degree comparing to head circumference. Asymmetric IUGR is more likely associated with uteroplacental insufficiency. هنا due to uteroplacental insufficiency there is a reduction in oxygen transfers to the fetus, and so this will lead to impaired excretion of CO2 by the placenta and fall in the partial pressure of O2 and rise in the partial pressure of CO2 in the fetal blood induce a chemoreceptors response in fetal carotid bodies. which resulting in vasodilation when in brain, fetal brain and myocardium and adrenal gland. And there will be formation of vasoconstriction when in the kidney and supplanking vessels, limb and subcutaneous tissue. The liver circulation is also severely reduced. Then, this will result in these circulatory changes lead to asymmetrical fetus with a relative brain sparring, reduced abdominal girth and skin thickness لأنه blood supply to the skin is less. The vasoconstriction in the fetal kidney will lead to oligohydramnios. The fetal hypoxia also lead to severe metabolic changes in the fetus. Regarding hematological changes, also there is a chronic hypoxia. Chronic hypoxia will lead to an increase in the level of erythropoietin and enucleated RBC. Chronic fetal hypoxia lead to fetal acidemia. If prolonged, this will lead to intrauterine death if the fetus is not removed from its hostile environment. Fetal growth restriction are especially at risk from profound asphyxia in labor due to further compromise. يعني هو during labor there will be decrease in the blood supply during contraction or during uterine contraction. In FGR fetus it is already compromised. So in normal labor during contraction, this will lead to further compromise of the uteroplacental circulation by uterine contraction. نيجي على causes of fetal growth restriction. Number 1, reduced fetal growth potential as seen in aneuploidies as trisomy or single gene defect or sickle syndrome. Also occur in structural abnormalities, renal agenesis, intrauterine infection, as cytomegalovirus or toxoplasmosis. Number 2, عندنا maternal factor ممكن يكون المother undernutrition as in poverty or eating disorder or maternal hypoxia when women living in altitude, cyanotic heart disease, drugs and alcohol, cigarette and cocaine. Number 3 is placental factors which reduce the uteroplacental perfusion as inadequate trophoblastic invasion or sickle cell disease, multiple gestation, reduced fetoplacental perfusion as in single umbilical artery twin to twin transfusion syndrome. هسه نجي على pregnancy اللي ممكن تكون at risk for IUGR, multiple pregnancies, history of FGR in a previous pregnancy, current heavy smokers, current drug users, women with underlying medical disorder, hypertension, diabetic mother, cyanotic heart disease in the mother, antiphospholipid syndrome, pregnancy where the symphysis fundal height is less than expected. Also carry risk of development of FGR. هسه نجي على diagnosis of FGR. أول شي by ultrasound evaluation of estimated fetal weight. شلون نسوي له diagnosis؟ عن طريق ultrasound biometric parameters on ultrasound indicate that estimated fetal weight is less than 10 percentile for gestational age. نجي على clinical finding by careful attention to gestational dating عن طريق menstrual history, serial examination, biochemical pregnancy testing, quickening and ultrasound. First sign of FGR may be lagging fundal height on a clinical examination. If the fundal height varies from assigned gestational age by more than 2 cm. Ultrasound is indicated to assess estimated fetal weight and amniotic fluid volume. And this has a sensitivity of about 46 to 86% for detecting FGR. Complications of FGR. Complications of underlying maternal disease يعني complication اللي هي as a result of already complication found in the mother, the pregnant woman, as a premature labor, preeclampsia, operative delivery, perinatal morbidity and mortality due to hypoxia, metabolic acidosis, intrauterine death, neonatal complication, and they are most very important. Meconium aspiration syndrome, low Apgar score, seizure, sepsis, polycythemia, hypoglycemia, hypocalcemia, and RDS, and incidence of sudden infant death syndrome is increased at neonatal period. All FGR infant required postnatal evaluation for congenital anomaly. And the long-term prognosis of FGR infant may have a neurological and intellectual deficit, lower IQ, higher incidence of learning and behavioral problems. Adults who are FGR at birth, they become at high risk for development of ischemic heart disease, hypertension, stroke, diabetes, and hypercholesteremia in future. ثلاث محاور نشتغل عليها إنه أول شي هو ال fetal assessment evaluation of fetal compromise. عن طريق شلون نسوي لها evaluation؟ عن طريق ال biophysical profile and Doppler study of umbilical and fetal vessels. In addition to a detailed fetal anatomic survey to exclude any congenital structural anomalies. Number 2, maternal assessment عن طريق detailed maternal history, examination, laboratory testing, and maternal serum testing to assess any complication that carry a risk of FGR, as well as preeclampsia, diabetic, maternal serum test for viral and parasitic infection if she has a history suggested of recent infection. And also by biophysical profile for assessment of fetal well-being. With a normal biophysical profile score, risk of fetal asphyxia in the following week is low. Also, as a part of biophysical profile, we have amniotic fluid volume assessment. Decreased amniotic fluid is clinically associated with IUGR. Oligohydramnios, which is known as oligohydramnios, which is oligohydramnios defined as a maximum when the maximum vertical bucket of fluid is less than 2 cm or amniotic fluid index less than 5 cm. They may be seen with FGR infant. Presence of normal amniotic fluid index should not preclude the diagnosis of FGR. يعني البيشنت إذا هي FGR or suspicion of FGR and by ultrasound amniotic fluid volume is normal, this does not exclude the diagnosis or preclude the diagnosis of FGR. Regarding umbilical artery Doppler velocimetry, placental circulatory insufficiency is associated with increased placenta resistance. As we see here, there is a Doppler velocity waveform. هنا normal, هنا increased impedance, increased resistance, هنا absent or absent and diastolic flow absent. هنا نشوفها ماكو، وهنا reverse and diastolic flow. نجي على النقطة الثالثة، يعني احنا قلنا fetal assessment أو maternal assessment، بعدين assessment of fetal growth عن طريق ultrasound examination to assess adequacy of fetal growth. This is done at least every 3 to 4 weeks. These measurements include parietal diameter, head circumference, abdominal circumference, and femoral length, especially in patients whom asymmetric FGR fetus is suspected. Most sensitive index of asymmetrical IUGR is abdominal circumference. هذا كلش مهم أنه تخلون ببالكم most sensitive index بالالتراساوند هو abdominal circumference اللي نرمزلها AC. نجي على time of delivery. Every FGR pregnancy must be individually assessed for optimal time of delivery. زين. this would be whenever surveillance indicate إيش وقت إحنا نسوي termination أو نقرر إنه patient should be terminate. But when the fetal maturity gain or fetal compromise, or when gestational age of 37 to 38 week beyond which time there is no advantage to the FGR to remain in the utero. FGR fetus to remain in the utero. The mode of delivery also individualized. Cesarean section or delivery is often indicated. And when we need terminate by vaginal delivery, continuous electronic fetal heart rate monitoring should be performed during labor in all cases. هسه نجي على large for gestational age pregnancy. By definition, when the estimated fetal weight greater than 90th percentile for gestational age on ultrasound, macrosomia represents a subset of large for gestational age fetus weighing more than 4.5 kg. Pathogenesis احنا اعتقد اتكلمنا عليها بالdiabetic pregnancy. Risk factor for fetal overgrowth obesity, diabetic patient, postpartum pregnancy or gestation, multiparity, multiple pregnancy, multiparity, large size of parents, advancing maternal age, and the previous macrosomic infant, racial or ethnic factor. Clinical finding of large for-date pregnancy. First sign of macrosomia may be detected when the fundal height measurement on clinical examination exceeds margin of more than 3 cm for the gestational age. Number 2, diagnosis of macrosomia is made when the estimated fetal weight on ultrasound is exceed 4.5 kg. The best single measurement in evaluation of macrosomia in diabetic mother is abdominal circumference by ultrasound. Complications for large for gestational age or macrosomia are cesarean delivery, prolonged labor, postpartum hemorrhage, operative vaginal delivery, and emergency cesarean section. Shoulder dystocia also is an important complications in macrosomic gestation, as 10 to 15% of infants with shoulder dystocia experience brachial plexus injury, facial nerve injury, and fractures of humerus or clavicle and stillbirth. Perinatal trauma, vaginal delivery of macrosomic infant, increased by 5-fold risk of 3rd or 4th degree laceration. Regarding the neonatal complications, low IUGR score, hypoglycemia, hypocalcemia, polycythemia, jaundice, and feeding difficulties. Large for gestational age infant of diabetic mother have increased incidence of cardiac septal hypertrophy. Management. Labor induction for suspected macrosomic gestation has not been shown to reduce the risk of shoulder dystocia. Also, cesarean section delivery and reducing the incidence of fetal macrosomia intrapartum complications remain an unproven hypothesis. Several published reviews of fetal macrosomia suggest that routine cesarean delivery for fetus with estimated weight of 5 kg or more, or estimated weight more than 4.2 or more than 4.5 kg in diabetic pregnant women. Intrapartum management consideration should be focused on close observation of patient labor curve and avoidance of interventions that may be associated with increased likelihood of a traumatic vaginal delivery. شكرا جزيلا على حسن الإصغاء.